Okay, well, it gives me great honor to introduce our next speaker. I hope lunch was wonderful. And, you know, been practicing now almost 25 years. And there are very few areas in medicine that I can honestly say we have had a significant breakthrough. This is one of those areas. There was no treatment available when I first started. Then we went into what I consider horrific treatments. And now this has changed markedly. And obviously I'm talking about hepatitis-c virus, optimizing HCV treatment, continuity and outcomes, empowering pharmacists to take action. I think this is one area of medicine that pharmacists are going to have probably one of the most significant roles in managing these patients. And again, like everyone else today, we have one of the absolute experts in the arena. I have Dr. Michelle Martin. She's a clinical pharmacist at the University of Illinois Hospital and Health Sciences Center, as well as assistant professor at the University of Illinois Chicago College of Pharmacy in Chicago, Illinois. She received her doctorate in pharmacy from the University of Wisconsin, went on to do a pharmacy practice residency with focus in ambulatory care at the Jesse Brown Veterans Affairs Medical Center in Chicago, Illinois. You like Chicago. And a board certified in both ambulatory care as well as pharmacotherapy. Highly published in the HCV literature, and with that, I'd like to invite to the stage Dr. Michelle Martin.
Thank you so much. I'm extremely excited to be here today to talk to you about one of my passions, of course, hepatitis-c treatment. And I can't wait to get on with the presentation. I have been charged with keeping you awake after lunch, so I hope that we can work with this together and keep you on your toes and awake. So we'll move on here. My disclosures and our learning objectives for today. Hopefully we'll be able to all develop a plan to implement some system-wide screening initiatives for hepatitis C to identify those that have not yet been diagnosed. I also would hope that we would be able to identify the limitations of the previous therapy that we had back in the 1990s and early 2000s with interferon-based regimens. We'll be able to evaluate some of the new direct-acting antivirals for hepatitis C treatment and their use in therapy now. And we'll also talk about some of the actions that you can take as a pharmacist to address the factors that affect adherence for patients, as well as addressing the other challenges of treatment, such as the medication burden and adverse events. At this point, I'll review some of the abbreviations. This is the only slide that will contain the brand names for the medications that we'll discuss throughout the presentation, because this is a non-branded presentation. But before we launch into the treatment, I just want to go over some of the basics about hepatitis C virus. Hepatitis C is a single-stranded RNA virus, and it lacks a proofreading polymerase. And the reason why that is important is because it continually makes errors as it reproduces. Hepatitis C replicates at a 10 to the 12th replication rate per day. This is huge. About 10 to the 4th is the amount of replication errors that it makes. So that's why hepatitis C is so variable. We have 6 different genotypes available, or that are identified. And they range in genetic makeup between 30 and 50%. The subtypes, denoted by a letter, so 1A versus 1B, those vary between each other between 10 to 30%. In the United States, genotype 1 is the most prevalent genotype, and genotype 1A specifically dominates over genotype 1B. So about 55% of the people in the United States are genotype 1A, about 15% 1B, and then we have genotypes 2 and 3 in the United States as well, and those range 20 to 25% for those 2 genotypes. Hepatitis C is also the most common bloodborne infection in the United States. And this picture identifies the prevalence of genotypes throughout the world. So some genotypes are more prevalent in other countries or regions of the world. I'm not asking for you to be able to read all of these, but I just wanted to allow you the opportunity to identify the preponderance of red. Red meaning genotype 1, which is the most common genotype worldwide, as well as in the United States. You'll see some sprinkling of blue or the teal color in the Middle East and Egypt, darker blue in South Africa, as well as green more so in Asia, and then yellow for genotype 3, more so in the Pakistan area. And this is something just to see how the spread differs worldwide. So now that we know a little bit more about what hepatitis C is, how is it transmitted? It's a bloodborne infection, so patients that would be at high risk of hepatitis C transmission include our patients that have used IV drugs. So even those patients that used IV drugs once in the 70s or once in the 80s, before we even knew that hepatitis C existed. Another fun fact is that hepatitis C actually can live in a syringe or in a needle for 63 days. So thinking about that, when you're thinking about patients that are sharing IV paraphernalia for drug use, 63 days, that patient is likely to become infected if they're sharing needles. A patient that received a blood transfusion prior to 1992 or a solid organ transplant prior to this time as well would also be at risk for hepatitis C transmission. And the reason for that is because we weren't testing the blood supply because we didn't have an adequate hepatitis C antibody until July of 1992. Also, patients that received clotting factors before 1987 would be at risk. Some other lower risk areas for transmission of hepatitis C include hemodialysis. The rates range dependent upon the area. Also, patients that have shared paraphernalia for intranasal drug use as well. Occupational exposure. If one of us actually has a needle stick in practice, we're more likely to get hepatitis C compared to HIV or even hepatitis B. Patients that receive tattoos through unprofessional manners, such as our patients that were prisoners and received tattoos in prison, or these new tattoo parties that are going on with the teenage patient population, it's very concerning. Also, there's a smaller risk of perinatal transmission. It's much higher if the mother's also co-infected with HIV, though. Sexual transmission was discussed a little bit more recently in the last few years regarding the men who have sex with men patient population. Typically, there's amphetamine use and higher risk sexual practices at this point. So now that we know how it's transmitted, who should we screen for hepatitis C? So the guidelines have said, screen everyone who has a risk factor. So this means that we're expecting our physicians or other healthcare professionals to ask patients invasive questions about their history. A lot of patients, I'm not sure if you've had this experience, but not all of them always are excited about telling the truth, especially if it is something that they may not be proud of. So I've had patients that have used drugs once or twice back in the 70s or 80s, and it's like pregnancy. If a patient has sex, they can get pregnant. If the patient used IV drugs once, they can get hepatitis C. It's as simple as that. It's just that our patients aren't always excited about talking about it. So recently, since 2012, the CDC, the U.S. Preventive Services Task Force, as well as the American Association for the Study of Liver Diseases, have all recommended this one-time screening for patients that were born between 1945 and 1965. And that's because at this point, 75% of our patient population with hepatitis C was born in that age cohort. So that's why we're missing a lot of these infections. And it's just important to screen this age cohort regardless of screening for risk factors in that specific patient population. So you don't have to ask the patient those questions. You just say you were born at this time, you should receive a hepatitis C test once. We also should be screening patients annually if they have continued risk factors, including patients that are using IV drugs or men who have sex with men that are HIV positive. So how are we doing on those screening recommendations? This cascade shows us how we are doing with hepatitis C. And I'm not sure if any of you have seen the HIV cascade, but we have a lot of work to do with hepatitis C. This was published in 2014, so it technically does not include the newest era of direct-acting antivirals, which came out in late 2013. This is showing on the left-hand column that we have roughly 3.5 million in estimate of patients in the United States with hepatitis C. But look at the next line or column. The diagnosed and aware, it's only 50% of that patient population. So what we're really missing is this huge, deficit between the patients that have hepatitis C and those that are actually diagnosed and aware. Our goal is to see this number of patients that achieve an SVR or a cure increase greatly over the next decade and even over the next few years. This cascade has not been updated, and I think now if we look at the number of patients cured with our currently available direct-acting antivirals, we would see a huge increase in that SVR patient population. So how can we screen? There are several places where you as a pharmacist can get involved in interdisciplinary hepatitis C screening. So I charge you to go out and hopefully try to implement some of these in your practice sites. Community pharmacies. The big thing with testing a patient in the community setting is to be able to link them to care if they do screen positive for hepatitis C antibody. This is the biggest factor because if you let them know that they've been exposed to hepatitis C, the next step is really getting them officially confirmed as diagnosed with hepatitis C and then getting them into care to hopefully treat the virus. We also can work with general medicine, primary care clinics to help increase the screening in that patient population. Infectious diseases clinics, those should be screening patients with HIV, certainly regularly. Colonoscopy suites. This is a great place to find patients that were born between 1945 and 1965, rolling in for their exciting colonoscopy upon turning 50. The emergency department is another area where we can screen patients for hepatitis C. They're coming in, perhaps they don't have established primary care and aren't seeing a physician regularly. We can screen these patients and then link them to care at the institution. Currently, the University of Illinois at Chicago is linking patients to care and doing opt-out screening for both HIV and hepatitis C. So when they come in and sign their paperwork saying that they will receive care or treatment at our emergency department, they're signing that they agree to receive HIV and hepatitis C screening if that's appropriate for them. So we're doing age-cohort screening at this time for the hepatitis C. Also, the inpatient services, we can identify patients born in that age cohort or those with risk factors as well. So we have a lot of different practice sites where we can start implementing these screening methods. And what exactly does it mean to be diagnosed with hepatitis C? Are we screening for exposure? And then how do we get to the point of diagnosis? So first off, we'll start with a hepatitis C antibody. Some labs have a fancy lab where they can, and ours finally does, but we can take blood for the antibody, and if it's positive, we can then go forward with checking the hepatitis C RNA level. Because screening positive for the antibody just shows exposure. It does not confirm chronic hepatitis C or a current infection. If the patient has both a positive antibody and a positive viral load, that would be chronic infection, and that's considered a diagnosis of hepatitis C. And then from there, we'll check the genotype to see what treatment options are preferred for that particular patient. We do have this new relatively new point of care testing. It's been FDA approved since 2011. And it takes about 20 minutes. We can do a finger stick for a patient. So this is great for performing hepatitis C screening in the community practice setting or at health fairs and other places where you're on the go. The caveats to this is that it's not diagnosing a patient with hepatitis C. The patient has to be educated that this is merely a screening. It just will tell us if the patient has been exposed to hepatitis C. So the big thing is that you need them to go in, link them to a provider to have that confirmatory blood draw to check their hepatitis C antibody and viral load at that point. So we cannot diagnose with the point of care test. So that's something extremely important to know. There are several articles that have been published recently that discuss screening in community settings. There was one published 2 months ago and another one coming out soon. My resident that I worked with a few years ago actually published her article on hepatitis C screening in the community setting as well. So how does hepatitis C progress? With acute infection, some patients will develop some symptoms such as jaundice, general malaise, fatigue, nausea. But a lot of times they just think that they're feeling under the weather. They don't necessarily attribute it to anything in particular. And then perhaps they'll actually spontaneously clear the virus. So 1 in 6-ish, maybe 1 in 4 patients will actually spontaneously clear the virus from their bodies. These patients are magical. We're now investigating how their immune systems are so incredible and can clear the virus. So this is extremely important, too, when we're looking at how to develop a vaccine. But the other unlucky folks will go on to develop chronic hepatitis C. So if you look at the timeline across the bottom, if a patient has chronic hepatitis C infection or a detectable viral load for 6 months, that's considered chronic hepatitis C. Those patients will go on to develop mild to moderate to severe hepatitis C, and then 1 in 5 will develop cirrhosis. And then from there, the patients that have cirrhosis or the most advanced form of scarring in the liver will go on to decompensate at a rate of roughly 3 to 6% per year. And for those patients that are decompensated, their liver is no longer able to function. They go on to end-stage liver disease and the need for a transplant. However, on the other hand, some patients that develop cirrhosis move on to develop hepatocellular carcinoma. So that's something that we need to screen for in our patients with cirrhosis, as well as advanced liver disease, or F3. So those patients, we need to look for this hepatocellular carcinoma and actively try to treat it soon if we detect it. So now we know how hepatitis C progresses. What is our goal of treatment? What we want to do is eradicate the virus. We want that virus to be taken out of the bloodstream. And this is defined as an undetectable viral load 12 weeks after the patient has completed the treatment for hepatitis C. So this is synonymous with SVR, or sustained virologic response. Back in the day, we had to wait 24 weeks after patients were treated with interferon-based regimens. And now we simply wait 12 weeks because the concordance rate with patients that did not have the virus relapse after treatment was at the same point at 12 weeks and 24 weeks post-treatment. By treating these patients, we want to prevent them from progressing to cirrhosis. We want to prevent them from actually having a decompensated condition and developing end-stage liver disease and the need for a transplant. We had a question over here. Okay. So many of you may be thinking, I've seen some of the insurance policies for hepatitis C treatment, and half the time the insurers won't pay for treatment. So what do we do with those? Why are we screening them? And the big thing for that is that if we screen them and we identify that they have hepatitis C, if they're F3 or F4, we can start screening them for hepatocellular carcinoma and hopefully prevent or early detect the development of cancer. For patients that do not have advanced disease, and all patients with hepatitis C, we can change their practices. We can alert them to the fact that they have it and hopefully decrease their transmission to another person. So how has treatment evolved over the years? Back in the 90s, we had interferon, this lovely treatment called interferon. Anyone remember treating hepatitis C with this back in the day? Horrible, right? So patients were treated with injections that caused flu-like symptoms, basically felt like crap, injection site reactions, could cause suicidal or homicidal ideation, all of thrombocytopenia. These things were horrible. Patients did not tolerate the treatment very well. And guess what? This is about how successful it was. About 1 in 10 patients would have success with the treatment. Then we figured out, okay, some other things that we can add on to make treatment a little bit better. But still, the challenges to treatment with interferon-based regimens were that it didn't work very well. A lot of conditions impacted the treatment success, including age, gender, specific genotype, or IL-28B, the age at which they contracted the hepatitis C virus, as well as the stage of disease. So patients that were later on and more advanced in their disease state did not do as well with treatment. And that's still, to a small extent, the same today. Patients with decompensated cirrhosis have more difficulty with treatment. But then we added ribavirin on, and then we, improved our treatment outcomes to roughly curing 25% of the patient population. Then we pegylated the interferon, so it was just 1 injection per week. So now I could work with my patients to schedule the injection for Friday so they could feel like misery over the weekend and then still go back to work on Monday. It was awful. It was a terrible time for treatment. It got us closer to roughly half of patients obtaining a cure, but you don't know until 48 weeks of treatment, then you wait another 24 weeks. A year and a half later, you may have a cure. And I'm talking about genotype 1 now when I talk about the newer direct-acting antivirals. So we first had protease inhibitors introduced in 2011. So in May of 2011, we had 2 new drugs on the market. And these, instead of being single-standing oral agents, these were just added on to interferon and ribavirin. We just wanted to increase the misery. So now, instead of just having all of the side effects of interferon-based treatment, we gave them rashes. We gave them anal itching. We gave them hemorrhoids. We also had a food requirement for one of them that was 20 grams of fat every 8 hours. So these are all the things that our patients went through to obtain roughly a 30% increase in cure, but still not quite as solid as the 90-some% response rate that we have today. And now once we cross the line, the direct-acting antivirals from 2013 on, we see huge changes in their SVR. So 92%, 97%. It actually gets boring because they're all in the high 90s. And that's the expectation at this point. If any new drug is coming for hepatitis C, we're expecting a 95% or above cure rate. So it goes on from 2013 until 2016. We had several new drug approvals for hepatitis C. This complicated the treatment course a little bit in that we have to now select which agent is appropriate for that patient. The great news is we have a lot more available for genotype 1, which is what infects the predominance of the patients in the United States and the world. So let's do a little cheat sheet on the drug names because it is confusing. We have all these combinations and we have the alphabet soup of the abbreviations. I just want to go through this for a moment and let you know that they're arranged in order of date of approval. So we have, starting off with the Previrs on top. Cimeprevir was approved in 2013. Then Paritaprevir is approved as part of the regimen with ritonavir, Bidasvir, and Decabivir. Grazoprevir was approved in 2016. I took off the Telaprevir and Boceprevir because they're no longer used. Those are the agents from 2011. And they all end in Previr. These are all protease inhibitors. So with the protease inhibitors, think drug interactions because you have the CYP3A4s. And also think not eligible for patients with decompensated cirrhosis. Those are the two big takeaways from the protease inhibitors. Then we have the NS5A replication complex inhibitors. And these are the Ledipasvir, part of the Ledipasvir Sofosbuvir component that was approved in 2014. Bidasvir, again, tied in with the Paritaprevir on top and the Decabivir below. Daclatasvir is a single standing pill, and that's used in combination with Sofosbuvir, and that was approved in 2015. And then we have Elbasvir, which is combined with Grazoprevir, and that was approved in January of 2016. Then the Buvirs, the NS5B agents, these are the polymerase inhibitors. We have Sofosbuvir, approved in 2013. Single pill, but also used in combination with both Ledipasvir as well as Velpatasvir. And we have Decabivir, which is part of that Paritaprevir, ritonavir, Bidasvir combination. So we'll go over these more now in detail. We'll talk about the potential drug interactions. So remember all the horrible things we said about interferon. How do these compare? I don't know about you, but I would much rather have a little fatigue because I'm alive anyways. And a lot of people, we don't know if it's the fatigue caused by the hepatitis C virus or if it's fatigue caused by the medication itself. A lot of my patients actually start to feel better after they've been on treatment for a few weeks. And I think that's because the virus is going away. And they had likely pre-existing fatigue from the virus itself. Some patients complained of more fatigue than others, but in general, it's extremely tolerable. Headache is the other potential side effect that is correlated with the majority of the agents that are available right now. It's usually mild. A lot of my patients will say they got a few headaches in the beginning of treatment, a few in the middle, usually mild enough where they don't even need to take over-the-counter pain relievers. So not a whole lot to write home about here. Certainly we do have to monitor lab work and things like that for the protease inhibitors because then we're watching for some ALT elevations. But overall, much more tolerable compared to interferon. I have a slide like this for each of the combinations that we use, and I started again with the first approved. So Cimeprevir, a protease inhibitor, and Sofosbuvir, that NS5B, these agents were approved. They're two separate pills, and they were both approved in 2013. This regimen was used heavily in early 2014, and its recommendation for use in the guidelines was based on a phase 2 trial, the Cosmos trial, which is roughly 160-some patients. This later gave way to a phase 3 trial that came out, and they had some wonderful SVR rates. So you can see down at the bottom for genotype 1, they range from high 80s to 90s. This combination is among the more expensive combinations because it's two different manufacturers, two different pills. The Cimeprevir needs to be taken with food. Sofosbuvir is with or without food. The Cimeprevir is not able to be used, or these agents are not able to be used in patients with a renal clearance of less than 30. So that's something to consider. If you have patients that are renally impaired, we only have two other options for them. So things to look out for, certainly the drug interactions. When you see protease inhibitor, think about CYP3A4 drug interactions and making sure that you're able to monitor them for that and adjust things as needed. But right now, this combination is used much less commonly. I haven't used it in about a year and a half. Then we had Ledipasvir and Sofosbuvir come out, and this was October of 2014. So this was the first single dose or single tablet regimen for patients with hepatitis C that was all oral. And this is used in patients with genotype 1, 4, 5, and 6. This was probably the most used regimen, well, definitely the most used regimen in 2015 because it came out in late 2014, was used heavily in 2015 before newer agents were approved later on in 2016. Something big about this one as far as drug interactions go is that the NS5A component, the Ledipasvir component, requires an acidic environment in the stomach for absorption. So you have all these patients that are taking PPIs over the counter or antacids or H2RAs. This is something that you really have to counsel them on. They can take no more than omeprazole 20 or the equivalent of omeprazole 20 concurrently, but they have to be counseled on spacing out antacids 4 hours before or after, and that H2RAs can be taken concurrently or spaced 12 hours after. As you can see here at the bottom with genotype 1A, the SVR rate was extremely high in the IONS 1, 2, and 3 trials, 94 to 99%. So excellent response for these patients. Then we had the paritaprevir, ritonavir, Elbasvir, and Dectabvir regimen come out later in 2014. And this one has all 3 medication classes for hepatitis C, so it's the only fixed dose combination that we have for all of those. That's something that gives us some benefits and certainly some drawbacks. For some patients that are treated with NS5A agents, they can develop resistance later on, so that will be across the board for NS5As. And this one also you would be concerned about potential NS3, although not a whole ton of that. This agent, we do have to worry about not using it in patients that have decompensated cirrhosis because of that protease inhibitor component to it. This regimen, because of the drug interactions, and it used to be a little bit more complex with its dosing, although now they made it a once daily dosing where it's 3 pills once a day. If the patient has genotype 1A, though, you're going to be adding on ribavirin. So that just makes this regimen a little bit more cumbersome for patients if they have to take 9 pills as opposed to other fixed dose combinations that only require 1 pill once a day. So it depends on what you're looking for in your patient. Drug interactions just much more prevalent than other agents. And then in 2015, we had the addition of Daclatasvir to our repertoire. Sofosbuvir and Daclatasvir can be used, again, it's 2 separate pills, which means double the copay. So this means it's much more difficult to get this combination approved, and actually at this point it's used much less frequently compared to some other agents. This you have to worry about, again, some drug interactions with the NS5A agent, and this is something that can have some drug interactions that cause you to change the dose of the Daclatasvir. So it's available in 3 different strengths, depending upon what agents are co-administered. It had great efficacy in genotypes 1 through 4 as well. It's only FDA approved in genotypes 1 through 3. And then we had the introduction of the first agent that was FDA approved for patients with dialysis, and this is Elbasvir Grazoprevir. So this agent kind of hit the market with a splash because now we could treat those patients with severe renal impairment. We also could use the PROD regimen for patients with renal impairment, but it depends upon if they're genotype 1A or not. Elbasvir Grazoprevir does require a specific NS5A resistance test at baseline to allow you to decide if it should be a 12-week treatment course or a 16-week course with the addition of ribavirin. So that's one thing to consider for patients with genotype 1A, which is, again, the majority of patients in the United States. Had great efficacy, so we really have a lot of benefits with our newer agents. They work very well. Then we had the approval of the pangenotypic, the first all-oral single-tablet regimen that was pangenotypic. So this works against genotypes 1 through 6, and it was approved in June of 2016. And this is able to be used in patients with creatinine clearance above 30. Big thing with the Velpatasvir component is that it does require an acidic environment for absorption. So they went a step further, and they actually don't recommend co-administering PPIs. If it's mandatory to, again, limit it to an omeprazole 20 milligram concurrently. But ideally, if we can get the patients off of any acid blockers, that would be best for treatment with these agents for 12 weeks. It was used highly in genotypes 2 and 3 because we had fewer agents available for these patients' genotypes earlier on. And again, we can use this one for any genotype. And this is not meant to be scary, but I just wanted to give you the idea of what the treatment options look like for patients based on their genotype. So on the left-hand column, we have the regimens that are available, and then we have genotype 1A. So 1A, most prevalent genotype, 1B also quite prevalent in the United States. The red font does indicate that that is an alternative regimen. Our guidelines are set up so that they say recommended and then alternative. So if I were you, we would choose the recommended option and then reserve the alternative for something where we couldn't possibly use one of the recommended ones. So lots of options here. This is for a patient that's treatment naive, who has never been on treatment before, as well as somebody who is not cirrhotic, so they don't have advanced liver disease. Look at what happens when you try to treat a patient that's treatment naive, but also now compensated cirrhotic or child PUA. Look at all the red. So this new red and also the extension of the length of therapy. So once patients get sicker, the treatment becomes more complicated. I don't know about you, but this makes me want to treat everyone sooner. We want to prevent them from getting cirrhosis. We want to prevent them from getting liver cancer. We want to prevent them from getting to the point of end-stage liver disease and needing a transplant. So treating them earlier not only makes the patient better, but it also makes treatment easier. So as a pharmacist, you have several roles, and we'll highlight some of those here today. In the ambulatory care setting, we have the ability to encourage screening and making referrals for treatment. We look at drug-drug interactions. We can educate patients and get them started on treatment. We also can work heavily with the community pharmacy or the specialty pharmacy to ensure that the patient actually gets treatment. And in this community pharmacy setting, again, drug-drug interactions, screening, educating patients on administration of the medication, working with refill management, and ensuring that you're linked up with the patient's providers. On the inpatient side, we can make sure that patients bring their own medication to the hospital to take it, because a lot of hospitals don't stock this extremely expensive treatment. We also want to make sure they're getting the appropriate labs drawn and that they don't have an interruption in therapy, unless it's preferred by the team or that they're stopped on therapy. So a lot of different ways where we can get involved as a pharmacist in all different practice settings. So how many of you have had a chance or have gone to the guidelines for hepatitis C? A few people, okay. So what's wonderful about hepatitis C guidelines is that now it's online. So it's updated live. Pretty much a week after new drugs are out, they update the guidelines, which is wonderful. When there's new evidence or data presented at national meetings, they update the guidelines. I actually created a case for my students in class on April 11th, and I presented it on April 13th. And then when I went to the guidelines and told all the students to go to the guidelines, they had actually changed the recommendation. I made it for a genotype 3, cirrhotic, treatment-experienced patient, and it had been updated on April 12th, which of course was embarrassing. But I showed them that this is what happens. Now the guidelines are updated so regularly, we have to really be on top of it. So don't memorize the charts that are in this presentation. Go to the guidelines directly for any future recommendations for treatment. They've updated them several times since they were first put online on January 29th of 2014. I printed it off that day, and it was 31 pages. And now if you go to the full report and try to print it, it's hundreds, and my computer freezes almost every time. How many of you have used the Liverpool Drug Interactions website? They have a fabulous resource for both HIV and hepatitis C. And hepatitis B. So there's a hepdruginteractions.org. There's also the HIV druginteractions.org put out by the University of Liverpool. This is where you can select your regimen for hep C, add in the co-administered medications that the patient is taking, and then it will spit out for you red, yellow, or green. Do not co-administer. Think about it. Or free for all. Go ahead. So it's a great resource for you. It's not all-inclusive, so you still may have to consult with other resources as well. So how can we make sure that our patients actually take the medication that we're giving them? We're signing them up for treatment that costs more than some people's houses. So we want to make sure that they're actually getting the most benefit from it, and we want to make sure that they're curing the hepatitis C. I've set patients' phone alarms in clinic. This is something that I like to do because a lot of patients come in and they have smartphones. So I set the alarm for them. I encourage them to use pill boxes. I give them medication charts. Everyone gets their own sheet that tells them what they're supposed to be doing for their hepatitis C treatment. Our specialty pharmacy calls patients usually every 2 to 4 weeks and also reminds them about the importance of adherence. The clinic setting, we can make calls outbound, and we do that as well. There are several manufacturer support groups where we can link patients up to a 24-hour nurse hotline so they can be the point of contact for patients. So how do we promote access? We also need to make sure that the patient's able to get the medication to begin with. In our clinic, I like to alert prescribers about the specific insurance requirements so that the patient doesn't have to come in 3 times to get all the blood work that's necessary for that insurer to approve the medication. I do write a lot of letters of medical necessity, unfortunately. A lot of medications get denied, and I have to appeal that with a letter of medical necessity. There are several patient assistance programs again. There are foundations that will assist if the patients have a $3,000 or $4,000 copay per month. They can likely get approval through a lot of these foundations, which is wonderful. So hopefully we can turn that denial into an approval. This is just a sample of what I provide to our providers in clinic. It tells them what medication or what insurers will require the patient to be sober for 12 months, or that they have to send a letter stating that they will take the medication as directed, or that they have to make sure that they have an alcohol screen in addition to the tox screen. So there are a lot of different nuances with insurers, and they're changing constantly. I update this chart usually once every month or so with any new information that I receive from the pharmacies that I work with. And again, this is just for your information. If you have patients that are starting hepatitis C treatment, we have the websites, phone numbers, and the potential agents that can help with assistance for on this chart. So what about the cost? I referenced it that it's extremely expensive. Here is from the Red Book as far as the cost of medications. If you're looking at the agents that are 2 separate pills and 2 different manufacturers, look at that nice, hefty $151,000 for a 12-week course. These prices, of course, are the reported wholesale acquisition costs. These are things that are highly negotiated by insurers, so when they select an agent to be their preferred drug, they're likely getting it at a much lower cost. But this is just the sticker price. Then we have the other agents here that are not co-formulated. Again, if it's a separate pill or a separate manufacturer, those are the ones that you'll have the highest cost for. And the 24-week regimens, I tell my patients, this is like a mortgage. So you want to make sure that that mortgage is going to pan out for you. So let's make sure that we can get this medication into your body for the entire course of treatment. This also can demonstrate why we have a lot of insurers that are balking at the price of hep C and wanting to delay treatment coverage until patients are more acutely ill, which of course is an ethical conversation that would take a whole nother 45 minutes. I just want to point out also the lowest price or wholesale acquisition cost is that of Elbasvir Grazoprevir, the agent that is able to be used in patients with dialysis. So how do we weigh these costs of treatment? We have on one side genotype 1 treatment for a patient that's naive and just needs 12 weeks of treatment. The treatment price can range from $50-some thousand to $90-some $1,000 as far as the single tablet regimen. Great, right? Then you think about, what about just waiting a few more decades until the patient develops cirrhosis and then has decompensated cirrhosis and then needs a liver transplant? Why don't we just push the cost off till some other insurer has to pay for this, like Medicare? Roughly $577,000 for liver transplant. So I don't know, but when I'm weighing the math here, I would like to treat my patient for hepatitis C now as opposed to delay the treatment and all the other morbidity and mortality that's associated with hepatitis C, diabetes, and all these other things that are worsened by having the virus. So ideally, we have treatment on one hand that is an easy regimen. We want something that's easy for our patients. Single tablet regimen is the easiest. 1 pill once a day. Of course, it could be 1 pill and that's all, but it's not quite as easy as a fluconazole. We have a short length of treatment, and I say we've achieved that because technically 12 weeks to me is extremely short compared to what we used to do to our patients with interferon-based regimens. Depending upon when they cleared, we could treat people for 72 weeks, and then some patients were on maintenance interferon. So 12 weeks, oral pill, one tablet once a day, to me is a huge improvement. We would love to have pangenotypic treatment available for everyone. And it'd be great if there were not any drug interactions. We have very few at this point for a lot of them. I think that we're still lacking in the affordability aspect and access because we have so many restrictions from payers about the medication coverage. We do have some remaining challenge with hepatitis C. We have the cost and access to treatment, of course. Screening and diagnosis. We have a huge goal of being able to screen these other 50% of patients that don't know that they have hepatitis C. Let's screen them and link them into care. Genotype 3 remains a bit of a challenge. That is the new difficult-to-cure genotype for hepatitis C. We do have some viral resistance occurring in patients that failed treatment. What happens if you're curing 95% of the patient? Well, the other few percent are not having a cure, so they're developing resistance. So we have to figure out how we can best manage those patients later on. And at some point down the line, we are hoping to have a vaccine for hepatitis C, although it's proven difficult. What's in the pipeline for us? Well, later on this summer, we'll hopefully have 2 new agents to add to our repertoire. We have an agent coming out that has a combination of a protease inhibitor. It's Grazoprevir, as well as Pibrentasvir, and it's an NS5A. And that has roughly 99% SVR rates in the trials that were presented recently. The agent they submitted the NDA in December of last year, and they're hoping for approval sometime in July or August. Gilead has an agent coming out. They're actually just adding a protease inhibitor on to the Sofosbuvir Velpatasvir agent that's already currently approved. Adding on that protease inhibitor will make it a triple regimen, or triple action regimen, but still a single tablet regimen, which will be nice for adherence. And then Merck has a combination coming out probably looking at 2018. So we have Grazoprevir as the common agent that was in Elbasvir Grazoprevir. They're just updating their NS5A agent and then adding on a protease inhibitor, adding on an NS5B agent as well. So these are all agents that are looking extremely promising. They're also going to be helping out with some patients with renal impairment, as well as looking at the patients that have failed treatment in the past. So more like salvage therapy for patients that had viral resistance to the other agents. This is my favorite list of resources for all of you to hopefully share and explore. I wanted to, of course, cite the guidelines up on top, and this is that live document. The Drug-Drug Interactions website can be extremely helpful if you're working for HIV or hepatitis C patients. And Clinical Care Options does great modules if you're looking to learn a little bit more about hepatitis C, as well as the University of Washington. They have some fabulous hepatitis C modules. So for all of you, hopefully this has inspired you to go out there and learn even more about hep C and bring your knowledge back to your practice sites. So in conclusion, hepatitis C is the most common bloodborne infection in the United States, but only half of the patients that have it actually know about it. So that's why it's our role to help get involved, start some interdisciplinary screening regimens, and get patients linked to care. Pharmacists can play an active and key role in these screening initiatives. And hopefully several safe and effective treatments are available right now, and we'll have a few more by the end of this year. So looking forward to that pipeline, hopefully a drop in the cost and an increase in efficacy so that we can treat and cure more of our patients with hepatitis C. Thank you so much. I have one question. Okay. Thank you. I have a few questions that I'll go over really quickly to help keep us on time. So the first question was about hepatitis C clinical testing, how it's checking for the hepatitis C antibody. So the question is, if a patient knows that they've contracted hepatitis C, but the virus is dormant and they're asymptomatic, would you treat them? So actually, if the patient does not have a positive viral load, they do not have chronic hepatitis C. So the diagnosis and treatment for hepatitis C relies upon them having a positive antibody as well as a positive viral load. So if they have just a positive antibody, but their viral load is undetected, that could mean one of two things. Either they spontaneously cleared the virus on their own, or they had treatment that was successful. So you don't treat if they don't have a positive viral load. In general, we want to treat everyone with hepatitis C, and the guidelines recommend we treat everyone except those with a life expectancy of less than 12 months. So really, we should be treating all of our patients, despite what the payers are telling us that they agree to do. Okay, so the next question was, for some patients that present with acute hepatitis that resolves, and then what is the chance of it becoming active again? If it does not become active, can it lead to cirrhosis and liver cancer? So the question is about the presentation of acute hepatitis. If you have a patient with the positive hepatitis C antibody, and they have extremely elevated liver enzymes, where you think you caught them in the acute transmission or the acute phase, this is something where a lot of times the providers will check the viral load and then check again in like 3 to 4 months to see. And technically, the actual chronic hepatitis C doesn't set in until they've had 6 months of chronic viral load. And if the patient is presenting with these acute symptoms, the jaundice, the malaise, the side effects of having acute hepatitis C, those are the patients that are actually more likely to clear compared to someone that doesn't have any symptoms at all. So those that have an extreme response with the jaundice and everything, those are patients that would be more likely to fall in that 1 in 6 patient population that clears it on their own. So again, we would not worry about it if we're able to, if we wait the 6 months, we can see if they clear it. If not, then treat them. Thank you so much.